Grüezi ragazzi, bienvenue und willkommen to Cannabis Ciencia's LinkedIn Live. Today we have a very special guest. Dr. Davide Fortin is joining us, and he will be talking about the relationship between frequent cannabis use and its relationship to the consumption of other depressant drugs. Just want to say a quick thank you to Cannabis Ciencia and to Viola Brugnatelli for making all of this possible. And without any further ado, I'm really ready to get into the presentation. Davide, why don't you introduce yourself briefly, and then you can take it from there.
Yes, thank you, Christina, and thank you, Viola, for the invitation to present my latest paper. So I'm a researcher, a postdoc economist at the University of Lille, where I'm studying the market and evolution of the market for heroin at the moment. But my research in the past has been mostly focused on the cannabis market and the cannabis consumers. So yes, so this is. So I'm an economist interested in the psychoactive substances, whether they're illicit or whether they are, in the case where they are used medically. And so cannabis has been my main interest. And the presentation of today is an article that it's in submission. It's going to be soon published, and it studies the profile of frequent cannabis users in European countries. Can we show the slides?
Of course.
Yes. So here it's of course has been the work. This work would not be possible with the other co-author, Vincent Leroy, Patrizia Carrieri, and Tanguy Barret from SESTIM at Aix-Marseille University. And what we're going to study, what we look in our research is how coping reasons, which we will see what it means, but how the reason of using cannabis are related to frequent use, and also how using other psychoactive substances has a relation, positive or negative, sometimes with an association with being a frequent cannabis user versus being an occasional users. So let's go for the overview. So here the context that we study is actually the potential substitution of cannabis with more harmful substances. But at the same time, potentially we could think that there are substances that could be used to substitute cannabis if they are less harmful. But in this case, we will see there is more the case that cannabis can substitute more harmful substances. So the methodology we'll use is a kind of complex multi-level logistic regression. We will see what it means, but we exploit a very large sample from many countries, so we have to deal with some heterogeneity, and we will see how we do that. And then we will understand how the results of our study have some important implication related to has harm reduction is done, especially now that harm reduction has been totally has been accepted also at the Convention for Narcotic Drugs of the UN last year, and so it's something that can be done in most in all the Western countries, but also in all over the world. And then we will also look at how this can affect slightly also the drug driving law, so the law related to driving with the presence of substances, which are laws that are being implementing recently and that have a very important impact, especially we see on frequent cannabis users. So how this interest that I had for this topic came from. So here we see a recent article from John Calkins, which looks at the trend in terms of the rates of being like a users that is daily or near daily. So we see this is from the United States, but we see how it has increased over the last 20 years as a percentage of population. And so what this imply, the fact that not only that people are using, that more people are using cannabis, but that more people are frequent and intensive cannabis users, have some implication, because we will have this profile that will become more and more prevalent, and it's unclear how this the impact of this in terms of social welfare and public health for different countries and for different social context. So we will try to understand and to identify who are actually these frequent users that use it daily or nearly daily. So first of all, the motives for using cannabis are very diverse, and this can include coping and therapeutic ones. So what is coping? Coping strategies can be sometimes confused with motives that are therapeutic, and this is mostly when cannabis is used to manage conditions or situations like anxiety, pain, or other symptoms. So cannabis is also used as a harm reduction strategy among people who use other drugs, and cannabis motive are related to cannabis use frequency. So yes, so there is some relation between these two, and the frequency of use is also like certain motives are more related to frequency than other, and in general, frequency of use is a strong predictor of both acute and chronic related problems. So to be very frequent users can be related to having some medical condition, some issue can be related. There is some relation, and among these also cannabis use disorder. So we try to understand in this context, especially which are actually the substances, the psychoactive substances that are associated with using cannabis frequently in a European context. And also which are the characteristics socio-demographic that are associated with being a frequent cannabis users. We also look at which use motives are associated with higher frequency. So we will see different type of motives, not only coping, but which are associated with this, and also if the pattern of use differ between those that use it for some coping or therapeutic reason and those using it only for some recreational goals, you know. And motivations or reasons. So first, we look at now the relation that we see between different psychoactive substances and the related harms. So different substances have different externalities to the individual that are using it, but also to society as a whole. So in just, for instance, like the impact that can have in traffic, in accident and car crashes. So we know legalization can affect the consumption of a substance, which can impose some substantial cost on society, and we have to see how the legalization actually affect this cost and if the benefit cost is positive or negative. That's how people decide, how policymakers decide to legalize or not. Only few substances have been so far studied for clinical trials. So, for instance, we have seen that CBD has the potential as a substitute for different substances. Now it's been studied, for instance, in a clinical trial in Australia to see if it can reduce the use of cannabis among intensive cannabis users. But there are very, very few actual substances that are studied for this. So we see that this is very limited because of some technical and economic barrier that are related to doing research with products that are plant-based, like cannabis, and this is because of some issue related to intellectual property rights and the possibility of those that do these clinical trials and invest to have a return in their investment, which is very difficult when you cannot really patent like a product that is used therapeutically. So because of this limit, there is a need also to use observational study to understand which substances can have the potential to be substituting other substances. Like more harmful substances. So what we see in terms of substitutability with illicit drugs and cannabis, we see that for alcohol, the criminalization or legalization have been found to reduce alcohol sale, binge drinking, and past month alcohol use in general in the North American context. We also have seen general population survey in Sweden showing like frequent cannabis users to be inversely associated with intensive alcohol use, and this was also like something that that could suggest that there is like a substitution effect, but more research is needed to prove that this evidence is solid. For tobacco, instead, there is not really evidence of association, or maybe tobacco can be reduced by cannabis legalization, but this is less clear. On the other hand, when you look at opioids and pain medication, we see that, for instance, for heroin, medical cannabis legalization has led to a reduction in heroin treatment admissions. In some cases, or in other cases, it did not affect heroin use, depending on which context has been looked. And for prescription opioids and pain medication, there is some evidence that legalization reduced the prescription. And also, there is recent evidence about cannabis being useful to manage opioid craving, and this being one of the main motivation for people that using opioid to use also cannabis. And there is an association with like the reduction in opioid use, like in terms of self-assessed by those using it. And also for chronic non-cancer pain, there is been proved in terms of cost effectiveness that medical cannabis was comparable in effectiveness with opioids, but at the same time, actually, cannabis has the advantage to have lower discontinuation rates compared to opioids. So that seems like very promising, and that could be like some of the explanation on why cannabis is substituting opioids among those using it for medical reason. When we look at benzodiazepine instead, there is also very little research, but what we see is that cannabis can be associated with reduction or discontinuation of benzodiazepine description. On the other hand, looking at stimulants like cocaine, it does not seem there to be like any like substitution or complementarity effect. So it does not seem to affect the emergency visit or cocaine treatment admission in North America. So now we look at the methodology, what we have analyzed for our research. So this is a large sample of almost 35,000 last year cannabis users. So in this sample, everyone has been using cannabis over the last year. So what we analyze is the difference between those that are daily or near daily cannabis users, what we consider frequent users, which have been using it at least 20 days per month, and those that use it less than 20 days per month. So this is our sample. This is a sample from many countries, as I said, that was collected by the European Web Drug Survey, which is a survey that is launched from the European Union Drug Agency. The variables that we analyze for understanding the association of frequent cannabis use are socioeconomic and demographic, area of residence, cannabis motives, and coping motives, decriminalization of possession in the different countries, and which substances have been used in the last 30 days. And then we apply a backward stepwise selection procedure to identify which variable to keep in the final analysis. As I mentioned, this is we use random effect with countries. I mean, this is very technical information, but about the methodology. But in generally, we also do sensitivity analysis to analyze only those that use only cannabis and those that use also other substances. So to see if there's a difference in this group among cannabis users. So here is the results of all the variables we analyze. What you can see here, then we will analyze the different type of variables, but what you can see that the main variables that affect the probability to be a frequent cannabis users are the number of coping motives. So the more coping motives you have, so as you mentioned, the more kind of therapeutic motives, the more likely you are to be a frequent users. And then we see also other effects of socio-demographic and of the use of other substances. But let's start from the socio-demographic. Here we see the stronger association is with the age. So the older you are, the more likely you are to be a frequent cannabis users. And this is a very specific characteristic of the European users compared, for instance, to North Americans, where we don't see really this. This could be related to different reasons. We will talk about it later, but it's an interesting finding about the specificity of the European context. We see to being a student is less likely if you're a student or you're a working student to be a frequent cannabis users. On the other hand, to be a self-employed is more likely to be, so not having like an employer, but to be self-employed, increase the likelihood to be a frequent users. Being a university, having a university degree, lower the likelihood, and also to be female, lower the likelihood to be a frequent users. Now here we look at the cannabis motives and specifically the coping reason. So which are the 4 coping reasons that we analyze? So this is those that declare to use cannabis to reduce stress or relax, to use it for improving sleep, to use it to treat depression or anxiety, and to use it to reduce pain or inflammation. So you see that the more of this, like, so that of these motives, the more likely you are to be actually a frequent user. On the other hand, we see those that use it for curiosity are actually less likely to be frequent users. And on the other hand, and those using for fun are a little bit more likely, but much more likely are those that use cannabis for performance enhancement. So for some sort of productivity or activity, like physical or mental. So now when we look at actually the difference of the 4 coping motives on the likelihood, it's quite important. Like, here we have that there is some problem with the slides. So yes, I'm okay. So let's what I couldn't not show is actually that there is an association, a different relation between with using other substances, but we will discuss this now very briefly. So so we see that frequent cannabis use is strongly and those dependently associated with reporting coping motives such as stress, anxiety, depression, sleep, and pain. And then we see frequent cannabis users are less likely to use heroin, alcohol, and benzodiazepine. This one I could not show it because there was some problem with the slides, but we see that we see a very strong effect in terms of substitution with heroin, alcohol, and benzodiazepine, mostly on heroin and alcohol. And on the other hand, I couldn't show, but there is actually a positive association. Actually, I go back here to show you. So. So here we see for the other substances, we see that cocaine and ecstasy and MDMA and amphetamine, so stimulants in general, are or also are positive related with being a frequent users. And on the other hand, and also LSD and mushrooms, so hallucinogen and psychedelic substances are also positive associated with being frequent users. And on the other hand, we see benzodiazepine is slightly negative associated, and heroin and alcohol are much more negative, so there are more substitute, as you said. When we look also at tobacco instead, tobacco is very positive associated with being frequent cannabis users, which in Europe seems kind of something we see, that there is the association of cannabis and tobacco because compared to the US, we tend to mix the 2 substances. But when we see this positive association with stimulants and LSD, there might be some complementary effect on using them, especially for hallucinogen like LSD and mushroom, or for stimulants. There might be some effect in the sense that after you use the stimulants, cannabis might be used as a way to fall asleep or to be able to sleep better, actually. But what is interesting here is that we see, as I said, the substitution for alcohol is much stronger compared to benzodiazepine in terms of the probability to be a frequent user is like decreased the probability to be an alcohol user in the last 30 days. So when we see this, we must think about also the way that cannabis is regulated, which is actually more similar to alcohol and benzodiazepine, for instance, from alcohol compared to other medication like benzos. But this is because, for instance, the way that for instance in the drug driving law are protecting cannabis users more similarly to alcohol than cannabis users that use it as a medication. And so when we think about this, there is a discussion to be made on how actually a physician would decide how to prescribe to prescribe between benzodiazepine and cannabis for people that have issue like anxiety or insomnia. And the decision from the physician is based mostly on 3 different type of factors. So the first is actually the efficacy and side effects that we see for this condition of these 2 products, these two potential therapy, the reimbursement policy. And here we know that reimbursement policy are much more like you're much more likely to get reimbursement for benzos than for cannabis at this point, but also the legal protection for workplace or drug driving laws that you can have for using both product for this condition. So the drug driving law are actually considered one of the major barriers to access to become a cannabis patient, because compared to like we can have a medical defense for driving under the influence of psychoactive drugs when they have a therapeutic application and when they're prescribed and taken according with prescription. But only few countries apply this exception for cannabis patients, while this is much more applied for other prescription medications. So as I mentioned, cannabis patients are more treated more like alcohol drinker than sick individuals. That's a big issue because that creates as I said, that creates an incentive for cannabis patients that are actually using it for medical reason, as we saw, to not have a prescription and not be able to access to medical cannabis, and because they cannot be protected actually because of using that. And we see that there is a trend from policymaker to identify what if someone is impaired or not while driving, just based on the presence of specific level of THC in biological sample, like saliva in France or in Italy right now. And this is very similar, as I said, to alcohol restriction and alcohol laws. So this test often fail to discriminate between impaired and unimpaired drivers, just about the presence of to look only at the presence of THC or to above a specific threshold, like that can be 10 nanogram. But this is this is even more important for frequent cannabis users, which will always have like some sort of level of THC in their blood if they're frequent users. But as we said, these frequent users are using it because most of the time for coping reason, for some sort of therapeutic motivation. And actually, the first studies of impaired driving that have been studying the effect of impairment on cannabis patients after use found no impairment, even when they are using a very large amount of product. And this could be due, in fact, by the improvement of the clinical symptoms of this patient because of the condition that they have, that may offset any detrimental cognitive effect that cannabis can have on users because of its psychoactive effect. So overall, the European Commission has estimated that driving under the influence of benzodiazepine is considered much more dangerous compared to driving under the issue of cannabis. So this should be something that should be faced by policymaker, and this drug driving law should be actually following more like what is the actual science than some easier way to fix it. So if a substance acts as a substitute for cannabis, not to conclude, when a substance is a substitute for cannabis and impose higher expected harms, this cannabis could be used as a treatment for drug use disorder of this substance. So could be also used as a treatment for lowering or stopping the use of alternative medication due to its side effect and low efficacy. So in this case, we see that which are the substances that are substituted by cannabis from our study are actually alcohol and heroin. That this is the ranking of harms from different substances. Here you see the harm of users and harm of to others. This is from a NAT study, famous NAT study. And we see that both alcohol and heroin, which are substituted by cannabis in our case, are more harmful. So cannabis could be considered as a way to as a treatment to substitute the use of these substances for those that have disorder with those. And the same, I mean, here benzodiazepine is less harmful, but the more recent studies show that is actually more harmful. So yeah, I mean, that's also for benzodiazepine should be considered, and it's definitely more harmful in terms of the risk for drug life low. So yeah. So the implication for harm reduction are that what we found about the profile of frequent cannabis users, like this information can provide the knowledge base for the creation of drug social clubs, and the experience that we have with creating a safer polydrug use practice and environment. I mean, in this type of new concept that where people can use drug more safely and to reduce their harms, it's important to give information of optimal use patterns of when you combine different substances and optimal dosages to maximize the benefits and reduce the potential harms, as we mentioned. And there should be more qualitative research that target users that are using these more harmful drugs to understand the acceptability of cannabis as a substitute, and the motivation as well also for the polydrugs use of cannabis with other drugs. Thank you for the attention, and yes, sorry for the confusion with the presentation, but there was like some slide missing. Thank you.
Thank you so much, David. That was very informative. And I think that the research that you've done and the research that you've shown will really move the needle forward and advance more progressive policies towards increasing the safety of everyone. You know, like you said, reducing the reliance on other drugs. Yeah, we have a little comment here from one of our viewers on from YouTube, and yeah, if you can comment on that. Are you aware of that particular document, like the Transform Drug Policy Foundation? Maybe our viewer can post a link to a particular document. But are you aware of any policy that is moving in that direction?
Well, I think the policy that are implemented in Canada is probably the most reasonable for the moment, where the police has to check with behavioral test if the individuals that are driving are actually under the influence and if they're impaired. There could be other solution, a little bit more high tech in the future, for instance, to create like some baseline of how people are driving while they get like a driving license, and with like some electronic software, so that you know how you are while you are sober, like, and when you are driving sober, and then the police could compare this to like with suitable machine, suitable technology to when you are found in the street, to see if you are actually driving less good or better than that, like some simulated software, but that would require some technology, more technology involved for the police in the control, and also more time, I guess. But that would make it more reasonable if they don't want to do like just behavioral tests, like this is what's happening in Canada. But to just look at all this problem as we do this for alcohol does not make sense. Like, so that when above a certain threshold you're impaired, it does not work, because all the research show that this is not the case for cannabis use. And as I say, the latest research on medical patients, they actually show no impairment at all. And so how can you, because if you have some problem and cannabis remove the problem, like for instance, if people that have the morbo of the syndrome of Tourette syndrome, they have been proving to have more executive functioning, to improve their executive functioning with cannabis. And you can imagine with this type of problem to be like driving, if you don't have like this tick, is gonna make it easier to drive. But also these people in many situations, in many countries, most countries, are at risk to be to lose their driving license, just because they don't they have some THC presence in their blood, so that's really,
which we know can stick around for a very long time. And just the presence of THC or the presence of cannabis does not always equate impairment. And I think we need to draw a big line between frequent users, chronic users, and occasional users, because the effect will not be the same on an occasional user. I think that it'll be disproportionate, whereas for chronic users there is some tolerance that develops, and whether that, like, it seems that that can help people. Now, I know from personal experience, I was prescribed benzodiazepines for a while, and I found it to be quite dangerous as well. So first of all, I think that whatever issues I had that were being treated with benzos made me a worse driver than if I take a substance. So like you said with the example with the person who has Tourette's, if taking a substance will improve your executive functioning and your ability to function in society, then that is actually a positive effect. Yeah, and I know that for sure here in Canada and in Ontario specifically, the Highway Traffic Act does have an exception for medical patients. So you do need to be a registered medical patient in order to qualify for that exception. So if they stop you and you have cannabis in your blood or in your saliva, however they test it, then you are not automatically facing the consequences of impaired driving. If you're just if you don't have a medical prescription, I think it would be more complicated in terms of proving that your use is medical. And are you aware of so in Europe, what kind of regulations, what are the most permissive regulations in terms of driving and medical cannabis?
Well, in Europe, there is not many permissive regulation. I mean, I think, I mean, it's very different, but I would not. I mean, there are like certain countries that put like a limit, yeah. So yeah, I'm not sure. Yeah. Sorry, I have to leave because I have to leave the office. But
Okay, yeah.
no, I'm not sure actually about if there is like any regulation that could be considered a benchmark, but there is definitely some regulation like France and Italy that are definitely the worst because they're really doing THC presence as the evidence of impairment. And like also in Norway, for instance, they're putting different like level. If you, depending on how much THC you have, you get a harder, harsher sanction. So that's really treating like alcohol, and that's totally wrong. But there are definitely countries that maybe don't impose like they don't impose like just for presence of THC, they don't equivalate this with impairment. But I mean, the real risk of this that people don't consider is that also people that are using cannabis normally, and they, as we saw, like most of people, which now I couldn't say the percentage, but the majority of people that are frequent users, they use cannabis, and that are frequent user, they use they have at least 3 coping reasons to use cannabis. So among the 4 that I show, stress, pain, and sleeping and depression. So they are like real people that have some real use of they receive some benefits, and these people, if they cannot use cannabis because of the risk of driving, they might just decide to use other drugs that give a similar effect, but maybe they're not as effective. Like now there is like synthetic cannabinoids that cannot be like easily identified from drug test. And so what we risk to see, and actually some study have showed that, is that in like a saliva test that has been done in France, for instance, they've been analyzing all these saliva tests, and they found that in 5, 6, 7% of those, there was some new psychoactive substance inside. So that cannot be found by this rapid test. But so what we risk is that people are just going to use other products that cannot be identified, but that might be more dangerous, and they might be less useful to treat the condition that they have. So this is just not very efficient, and this is like we're not allowing them to use the best therapy for what they would need. And so this is really something that I think should be considered, and should be another reason not to imply this presence of THC as the only like signal of impairment, but there should be behavioral ones also test, or also there should be also to have a prescription should give you like total exception from this type of driving law. Yeah.
And then you mentioned that people have 3 or 4 different reasons for using
The
cannabis.
majority has at least 3, yeah.
Yeah. So
Of the frequent cannabis
when it
users.
comes to like specific medical treatments, there's also the risk that you get a separate drug prescribed for each separate reason. So then instead of using just cannabis for the 3 to 4 reasons, you're all of a sudden using like 3 extra medications, right?
Yeah, that's right.
And I just put down this your website if anyone would like to see more of Dr. Fortin's work. And yeah, if there are going to be any more questions, I'm going to reach out to you. Oh, we have one here. What other medical condition driving rules are best comparison for cannabis use? The guidelines for things like prescription opioids, benzos, sleep apnea offer better lessons. I think you already addressed this with the previous comment. Yeah. And I think that the legislation is going to have to move forward, and there's just going to be a need for collaboration across the ocean to share data and really make informed decisions that are going to protect everyone in society. Nobody wants impaired drivers, whatever the substance that they use is. And also it seems that it is very possible to reduce other dangerous substances and replace them with cannabis, other substances that are more dangerous, especially from addiction perspective as well, right? We're talking about heroin, alcohol, and benzos. Those are all highly, highly addictive. Yeah.
Yeah.
All right. Well, thank you so much for joining us, David. And
Yes.
yeah, the presentation is available. The recording is available. Thank you so much, everyone. Have a good day.
Have a good day.